Let's go ahead and just get everybody started. My name's Autumn. I'm a member of the outreach team here at SunCloud Health. Thank you guys so much for joining us today for our National Clinical Collaborative Learning Series. SunCloud provides the full continuum of care for adults and adolescents, focusing on customized and integrative care with locations throughout the Chicagoland area, including Northbrook, Lincoln Park, Naperville, and our newest addition in Matteson, Illinois. For today's CE credit, you will receive an email including the quiz and the survey. Please complete these to receive your CE certificate by email. You should expect to receive your CE certificate within the next 7 days. You will also receive a copy of today's PowerPoint in the email, along with a link to leave a Google review of your positive experience with SunCloud Health's continuing education opportunities so far. We will also have links to register for the next CE events at the end of this presentation. So please register for more of our CE opportunities through SunCloud Health. Today's presenters are Colleen Kestel and Martha Curtin. Colleen is a healthcare executive and a registered dietitian. She has a master's in business administration and a strong clinical foundation with extensive experience overseeing multidisciplinary teams across residential and outpatient behavioral health settings. She has led operations, compliance, and clinical support services with direct oversight of nutrition services, regulatory readiness, and program performance across levels of care, including residential treatment, PHP, and IOP. Her leadership experience includes the development and launch of residential treatment facilities, as well as the expansion and optimization of existing programs. Colleen has played a key role in building operational infrastructures, ensuring regulatory compliance, and driving quality improvement initiatives to support sustainable growth. In addition to her operational leadership, Colleen brings a strong clinical foundation as a registered dietitian with experience supporting patients and families navigating eating disorders, mental health conditions, and co-occurring disorders. She integrates this clinical perspective into her operational approach, ensuring a patient-centered, high-quality care delivery. In 2022, Colleen co-founded a Joint Commission accredited intensive outpatient program in Will County, addressing a critical gap in access to care. She returned to SunCloud Health in 2024 as the Director of Operations and now serves as the Vice President of Operations, where she continues to lead strategic growth, program development, and organizational excellence. Martha Curtin is a dedicated physician assistant in the Chicago suburbs with a strong passion for sleep medicine and for expanding access to care for urban, rural, and low-income communities. She finds sleep medicine deeply rewarding, caring for patients across the spectrum of sleep disorders, with a particular expertise in narcolepsy, idiopathic hypersomnia, and sleep apnea. In her clinical work, Martha emphasizes that a diagnosis does not define a patient's potential and encourages every patient to feel confident advocating for their needs. Martha enjoys lecturing on sleep medicine at schools and hospital systems to increase awareness of a field often underrepresented in medical, nursing, and PA education. She also serves as a pharmaceutical advisor, helping guide treatment approaches and supporting clinicians in becoming more comfortable with a full range of therapeutic options to optimize patient outcomes. She's earned her bachelor's degree in kinesiology from Eastern Illinois University in 2010 and her MSPA from Southern Illinois University School of Medicine in 2017. Before transitioning to sleep medicine, Martha practiced as a hospitalist PA in rural Southern Illinois. Outside of work, she enjoys spending time with her husband, 3 daughters, and staying active through hiking, gardening, and long-distance endurance events, including completing a full Ironman triathlon. Wow. At this time, I'm going to turn it over to Colleen and Martha. Thank you guys for coming, and we'll talk soon.
Awesome. Thank you, Autumn. We're so excited to have everyone here. What Martha and I find really important is that we have some engagement from the audience because we want to hear what you guys are looking for, questions you have, or your own experiences in the field. So throughout the presentation, if you have a question, instead of waiting to the end, if you can please raise your hand in the Zoom feature, and then Autumn will allow you to unmute and ask that question. So we'll give that a try so we can have participation. You're welcome to still type questions in the chat, but There's going to be times that we would rather you guys engage in the conversation throughout the presentation instead of waiting until the end. All right. Okay, just to make sure, Autumn, can we all see the screen that I'm sharing?
Yes, it looks like we can.
All right, wonderful. Okay, so this is what you all signed up for. These are the objectives that we're hoping that you guys have some takeaways for today and maybe some even more. Okay, so before we get started, we have a bit of a self-assessment for you. So if you guys can take a minute, read through these questions and just think about what the sleep and nutrition assessment looks like for you. Well, we would love to hear what you guys are thinking as these questions come up. So, does anyone have anything they want to share or add to the chat? Just to get our brains going before we get into the topic.
I have many patients, just to comment on, like, you slept for 4 to 5 hours, midday crash hits you. I have many patients that will tell me, well, I only need 4 hours of sleep. I say, oh, okay, there are rare scenarios where that's the case. What does your day look like? How do you feel? Oh, I feel awful. I drink caffeine in the morning. I do an energy drink in the afternoon. And so then we revisit. Do you really only need 4 hours, or are we compensating throughout the day? So I love these prompts. Let's see. Some people did respond in the
Yeah.
comments here.
It seems like we have a good variety of some outcomes and behaviors of how people are managing this.
Great assessment, LOL. I'm currently drinking my midday coffee.
Yes.
I rely on coffee too much.
Which we will be talking a lot about caffeine.
Recognizing how much caffeine we use is normalized. That's very interesting, and we'll talk about
and it only temporarily improves our alertness. So it puts us
Agreed.
back in the cycle.
But I want to add one thing real quick. I can't help but notice when I see a new 7 Brew open or a new Starbucks or scooters, the lines wrapping around. All I can think is this is job security for me in sleep medicine.
Yeah. Yeah, it's become so normalized and popular.
Yes.
All right. Well, I hope everyone had some good takeaways from that. So looking at now, like why you all are here, why this matters. A sleep deprived brain is less cognitively flexible. So you guys can see here that we have these patterns that are more common than most people realize, and they help illustrate why sleep deserves more attention in eating disorder treatment. And that goes without saying, just general mental health and normalized health. So sleep disturbance may worsen restricting binge cycles, emotional dysregulation, compulsive movement, and treatment resistance. And that might be coming from the false sensation of like they're not just the cognitive awareness. So because of that, the poor sleep might predict the worsened mood, a higher relapse risk, impaired cognitive flexibility, reduced stress tolerance. Sleep systems are often underassessed in eating disorder treatment. So our goal here today is to bring more awareness to that, and that's why we wanted to pair up with the two fields.
The impaired cognitive flexibility, that's really interesting. I feel like that's becoming more known to the public of dementia risks as well, wrapping it in with everything. As well as, I'm curious, Colleen, your perspective on, I know we're specifically focused on eating disorders today, but how does that relate to maybe disorder eating? Can you explain that?
Yes, it's almost like we scripted this, and I swear we didn't, but that's going to get us.
This
Yeah,
organic.
that's going to get us right into the next slide. That with feeding and eating disorders, some people struggle with that title or that diagnosis that they feel might be a forever thing. So I often, when I'm working with patients of, is it an eating disorder? Is it disordered eating behaviors? And my goal is that we all can make improvements. So let's, work on those steps that feel realistic for your recovery to better improve your life overall. We all have a body, we all need to feed it. So whether it's disordered behaviors, that might be something that all of us might have engaged in. Like, did we sleep late on Saturday and just have coffee, and then before you know it, you didn't eat before dinner? That's not necessarily what our body wants and needs. So we might have these disordered like patterns and behaviors that might lead up to like a full eating disorder. When I have a patient that struggles with not wanting that, I say, like, let's just look at the symptoms and treat it of where we want to be. We don't have to follow like strict, we don't have, it's not a cookie cutter of, oh, you have anorexia, so we need to do this, this, and this, and it's gonna improve. At SunCloud Health, we're really great at individualized treatment plans, which kind of going along that allows us to do. So as far as the DSM-5 with feeding and eating disorders, just not sure what everyone's experience is with eating disorders. So I just want to spend a minute on the different types of eating disorders. Some might be familiar to you all and some might not. So anorexia, this is like a severe restriction of their energy intake. That likely will lead to that significant low body. So there's this intense fear and disturbance in their body image that they don't want to gain weight, or their goal is to lose weight. And it's just typically never enough. So the restriction may involve calories or specific food groups or timing throughout the day, food rituals, avoidance of certain foods or certain situations. Patients may often experience cognitive rigidity and perfectionism with an eating disorder. So sometimes they feel like it's good behaviors, like, oh no, I eat the same thing every day and I make sure it's this, but it's that flexibility. We eat for two reasons. We want to nourish our body, but we want to honor those taste buds. So are they truly doing that? The low weight is individualized and based on developmental and medical content. Many patients deny hunger cues or feeling successful when restricting. It's, I want to do more. What's the next? So we have subtypes of the anorexia. It could be restricting, binge eating, purging type. So I'll get into binge eating. This would involve both these criteria: eating in large amounts of food in a specific time period or small time period, as well as a loss of control during these episodes. So even if a patient feels very full, they feel that they can't stop that behavior. It's not just about eating, the amount of eating, but it's the lack of control around the behavior. So again, often might be rigid, secretive, rapid, very emotionally distressing. So it's often feeling like numb or out of control. They could be, binges themselves can be triggered by restriction behaviors, which maybe lead to binging, and then binging maybe leads to purging or restricting again, and it's a cycle. It could be from sleep deprivation, emotional distress, shame, or emotional hunger. So we work a lot with, is it physical hunger or fullness or emotional hunger or fullness? Please, at any point, Autumn, let me know if someone has a question about this. Like I said, I don't want to spend too much time on the different types, but I'm happy to if needed. Next, we have avoidant restricted food intake disorder, so RFID. This is like the extreme pickiness that some parents think their kids have. But this is a restriction or avoidance of food not related to the body image like anorexia. This is a fear of a food that they feel that they cannot digest or bring food into their body, that we don't feel that there's a danger. So like, say someone with a severe peanut allergy, they're going to be afraid of peanuts, and that makes sense. So someone with avoidant food restrictive intake disorder is that very severe fear that could be related to sensory fear of choking or vomiting, or just a low appetite, or just a complete lack of interest in food. So it's common in kids. So we want to do some exposures and see what the reason is behind it, but it's also seen in adults. The goal for that is if patients are nourishing their body through the different food groups, we can work with that where they might just have limited variety, but we're getting the macronutrients and micronutrients still. So it's not a calorie deficit once we get to our goal of the meal plan. But they might.
Somebody in the chat was asking about anorexia and ARFID, and can you have both simultaneously?
Can you have both simultaneously? Oh, good question. Yes. And I think this would be a matter of what are we looking at more specifically. But the major difference is ARFID is not about the body and anorexia is about the body. So I think that intervention might look different, and then we're looking for clarity. So that might fall into more of the OSFED behavior of if it's a combination of the above versus one very specific. Was there any others, Autumn?
Not so far. I'm looking through them right now. I'll let you know if more come in.
Okay. So then we have bulimia nervosa. This is a recurrent binge eating cycle behavior that's going to have an additional behavior such as self-induced vomiting, laxative abuse, fasting, compulsive exercise. So some way to get rid of the calories after consuming them. This is heavily influenced by body shape, weight. They may feel loss of control, just not simply overeating. Some patients might be purging after no matter what they consume, not just after a binge. So this one is secretive, shame-driven. Their weight may remain normal. It could fluctuate within range. Then we have OSFED. There's 5 subtypes of OSFED, and later on we're going to focus on one specific that I think you guys will understand why. But the common examples of the different types, we have atypical anorexia, purging disorder, low frequency binge bulimia nervosa. So OSFED is not like less severe or less important. This is when there's a few different things going on that are in the different categories above that we've not necessarily been able to specifically pinpoint, or it falls into something like the atypical anorexia, as well as night eating syndrome, which this is where, just for sake of time, I do want to move on so then we can get to the sleep portion. So we have causes of eating disorders. You guys could see here, if there was one specific cause, we would be treating it that way. But we know it is a combination of so many things. And a lot of times we'll have parents or patients ask, like, what caused this? Why all of a sudden? And I say we may never find that why, but let's find the how and the motivation to be able to move forward from it. It's not like a lifelong decision. The recovery will need to be lifelong, but it's not necessarily like this stamp that it's going to be something forever. So, yeah.
I wanted to add in here that if we look at all of these are all factors to precipitate insomnia as well. There's biological backgrounds, psychological, sociocultural, family, environmental, and individual. So I wanted to add that right there is an overlap as well with insomnia.
Amazing. Thank you for that. So they can look very different clinically, but their developmental is usually the multi-factor and can be similar. Eating disorders are medical and psychiatric illness, not a choice or a phase. Someone isn't excited about this. So genetics can increase the vulnerability, but genetics alone don't cause the eating disorder. For psychological factors, it might be striving for perfectionism. It might be anxiety related. Many individuals using the behaviors are using it to cope with distress or overwhelming emotions and looking for a distraction or a numbing tool. Diet culture, really heavy and hard with the kids on social media. So that's something that we talk a lot about, of those negative influences and how many things are not actual true in the social media realms. So trying to get people to avoid those. For family environmental factors, it's how maybe someone's raised. Like, is their mom on the scale every day and the kid's like, oh, I want to be just like mom? Or is it less, let's eat less, or cookies are bad, good food, bad food. So again, not one thing is causing it, but it could be something that might lead into that. We want positive body and nutrition in the house, not comparing of each other. So then the individual factors. High achievement goals, impulsivities, obsessiveness may increase the risk. Early dieting behaviors, we look at a lot about fad diet trends. So again, no single factor can cause this eating disorder. Here are some statistics about eating disorders. These contributing factors also help explain the why of eating disorders. They're both common, highly impactful across the populations. So at SunCloud, we see about a third of our patients with an eating disorder, and greater than 15% of those have an eating disorder and another co-occurring addiction. So 9% of the population will have an eating disorder, whether you can see it or not. We aren't just fitting into this typical box of young female in a very small body has an eating disorder. That's by no means the truth behind it. So one thing that's important to share with you all is I think this is a very unknown fact that eating disorders have the highest mortality rate of any mental illness, which is just very powerful to think the impact that it has. And then it's really important. It affects people of all races, ethnicities, genders, backgrounds. It's not specific to one area. And our hope is that people of different genders and identities and backgrounds feel that the support is there for them, that they can get help too, that they're not fitting like that specific eating disorder box.
I have to chime in. Eating disorders have the highest mortality rate of any mental illness. Oh my goodness.
Mm-hmm.
When I read that, it's unbelievable.
Yeah.
In that one.
All right, Martha, I'm going to turn it over to you now for your sleep disorders.
Hey, fantastic. Well, I didn't get to say it. Thank you. Thank you, SunCloud, for having me. This is so much fun and exciting and a nice break in my clinic day to come enjoy the afternoon with all of you. So thanks for all being here. So sleep disorders, many different sleep disorders. So right now in your mind, I would love for you to think, what is the most common sleep disorder in America? Just think for a minute, most common sleep disorder. Someone says insomnia, sleep apnea. Excellent. Sleep apnea, okay. Thanks for the involvement. Sleep apnea, insomnia, or sleep apnea. It is insufficient sleep syndrome, meaning we don't sleep enough. Okay. And so that can be behavioral, and commonly is. Insomnia is part of it. Apnea is up there too, but insufficient sleep because of devices, because of work schedules, because of our culture. That's actually number one. And then those come in line. Insomnia and sleep disorder breathing are next. So insomnia is the difficulty falling asleep, staying asleep, or waking up too early compared to what you set out to do. And the DSM is at least 3 times a week for at least 3 months. But essentially, if someone comes into clinic and says, I can't sleep, I can't stay asleep, I can't fall asleep, we're going to call it insomnia and we're going to treat it and work with you. Okay. So that's one there. And in insomnia cases, 40 to 50% of those cases of insomnia have a co-occurring mental health diagnosis. And it's funny, I was at a gathering with a psychiatric nurse practitioner, and it's so funny because I'm sleep med PA, she's a psych NP, and we just bounce patients back and forth to each other trying to help because there's such an overlap, especially with the insomnia and psychiatric diagnoses. Sleep-related breathing disorders. So we know that with apnea, which is the most common obstructive sleep apnea, there are 2 types. There is obstructive, which is the more common, and that's a physical airway obstruction. And chronic nasal congestion or deviated septum can add to that, but it's typically back in the oral pharynx where this collapse is happening. And what happens is we fall asleep. When we fall asleep, our brain relaxes, our muscle relax, and then once the airway collapses and reduces in flow, we no longer get the oxygen to the heart and the brain. We have decreased oxygen, elevated CO2, so our brain signals, hey, you need to wake up and breathe. So multiple times an hour for people with apnea, their brain is waking them up to restore the airway to keep breathing going on. But during that time, many of us probably have heard the sympathetic nervous system or that fight or flight. That is how your brain is waking your body up to continue breathing. So we have elevated heart rate, elevated blood pressure, elevated sugars. well as elevated cortisol. And all of this is why we see the link with apnea of diabetes, hypertension, and the reduced flow to the heart and the brain, heart attack, strokes. But the elevated cortisol puts your body in a chronically stressed state. And this is very difficult to lose weight if you're trying all the natural, healthy ways to do it. So we start to see people gain weight further on, and we'll talk more about that if they have untreated sleep apnea. Central disorders of hypersomnolence, the main categories there are narcolepsy and idiopathic hypersomnia. Narcolepsy, there are two types, and I love talking about narcolepsy with groups like this because everybody can detect this. Registered dietitians, we have counselors, anyone in the medical field, but you just need to know it to look for. And one of the issues with narcolepsy is many people have the Hollywood version in their mind of Mr. Bean in the rat race passing out, or I've never seen Deuce Bigelow, but apparently somebody just falls asleep. So narcolepsy is not just falling asleep unintended on passing out on the ground. Circadian rhythm, sleep-wake disorders. So there's a couple types. There's delayed sleep phase, which is what we see in teens. And delayed sleep phase is when people are basically, it's the medical term for night owl. You have more of a chronotype, your inner body clock, that's shifted later than the average person. Then there's advanced phase sleep, where you want to go to bed earlier. And then there's people who work nights. And that circadian rhythm of night shift work disorder, basically. So your body doesn't naturally want to do that, but we're forcing it to because of work and culture. Parasomnias are any unwanted movements at night. So that could be sleepwalking, sleep talking. It could be noises as well. Anything that happens while we're sleeping that's some sort of movement. And in all parasomnias, you have to rule out apnea first, treat the apnea and see if it goes away, because that can cause many parasomnias. And then sleep-related movement disorders, the most common, restless legs or leg movements, as well as a key point here with eating disorders as well, especially in the, well, it could be in any of them, but anyone with any form of iron deficiency. If iron is low and stored ferritin is low, that can increase the risk of restless legs. And depending on who's in the crowd, you'd want to do blood work, iron and ferritin to be above 75. Technically, 50 or 40 is normal ferritin, but above 75 in regards to leg movements. Do we have any questions here?
Martha, we do have a question.
Let's hear it.
Has there been more research or newer diagnoses regarding social media usage contributing to staying awake, especially in relationship to teens?
Yes, let me see. Is our next slide the insufficient sleep? Let's see.
Sleep disorders.
Oh, okay.
If you want to jump around,
if you want to skip to the one where it's, there we go. So this one, interesting sleep statistics, but you're exactly right. And this isn't just for teens, this is for everyone. A lot of people think the only reason we need to plug in our phone at night is because of the light emitting. And yes, that's part of it. However, for some of my patients with insomnia, an iPad or TV or phone is actually beneficial. It's more important about what's being done on these devices. And so an example like social media, when you're scrolling and new information and you're getting new input constantly, that rises dopamine in your brain. New novel material increases dopamine in the brain, and dopamine is a wake neurotransmitter. So any kind of social media before bed is not good. Reels, TikTok, Threads, whatever other ones there are now, those fast videos, same thing, quick hit of dopamine, and that is releasing dopamine and waking your brain up before bed. If someone, I tell my patients, I'm like, you can read on your phone, dim it, and read about the history of the fork. You cannot watch reels. I want something boring. Read about twigs. It doesn't matter as long as it's boring and dry. But we can't, if we're constantly giving the brain information, and not specifically to teens, but phones in the room, we know are not good for teens. We do have responsible teens in the world, and I can plug it in and go to sleep. But typically when I have patients come in, I just have to help and support the parents in what they know they need to do is take the phone away, take the iPad away so that your child can sleep. The reason I wanted to go to this slide is because not just teens, but if you look at the breakdown of how much sleep an infant needs, we're all pretty good about that with our kids. But even toddler, preschool, school age teen, these ranges that are given for what's ideal for this age group, I'm seeing significantly less in clinic. And it has to do with 8-year-olds, 5-year-olds having iPads in their beds until whenever they want. And so that becomes more of a conversation with the parents. And I know parenting is difficult. I have 3 children, but this is really important because these stages of sleep, and we'll go through those next, these are peak growth hormone years for our children. Let's see what else we have here. Were there any other questions? Oh,
Yes,
sleep paralysis. I'm sorry, I just saw that one. We're going to get to sleep paralysis, but that is something we're going to discuss. Anything else jumping out right there?
Somebody was asking about the relationship between sleep disorders and mental health diagnoses.
Yeah,
Yes.
I
Go
would
ahead.
like maybe we can get through that more throughout the presentation, and
Yes.
then
Okay.
please make sure, Jessica, you come back if we did not hit your exact question. But I think
Okay.
there's more to come.
Yes. So basically, we know that the sleep statistics, the insufficient sleep is an issue. 1 in 3 Americans aren't sleeping enough. Our sleep is getting worse. 1 in 4 Americans develop insomnia each year on top of the previous ones. High schoolers are getting too little sleep. And like someone had mentioned, social media, phones are part of that. And we can back up then, Colleen, and go over sleep physiology.
All right, I gotta.
Someone else was asking about the sleep function on the Apple Watch. Is it accurate?
Yes, we're going to get there.
Yeah.
All right.
I knew what you were going to ask. We have a couple of different causes. So neurochemical imbalances in the brain, sleep pathways interfering with wake. So sometimes with dopamine, serotonin, that's why if someone has untreated anxiety, depression, that can be in itself some sort of imbalance that SSRIs, patients are sometimes put on SSRIs. We use those with insomnia and it improves their sleep by treating the underlying anxiety and depression. I also think of neurochemical imbalances in patients with narcolepsy. They have a lack of orexin, and orexin is a wake neurotransmitter. And so if we don't have enough, they're sleepy during the day, and actually their brain wakes up at night. We'll get more into that. Genetic factors, as always. Medication side effects. That's the first thing I look at is the med list. What are people taking and what could be affecting their sleep and their alertness? Substance abuse before bedtime. Alcohol can help you fall asleep, but it doesn't actually help you go into the deeper stages of sleep. So even though people think, oh, well, I take a nightcap and it helps me sleep, well, sure, it helps you get to sleep, but your actual sleep quality is not as good. Nicotine, heavy smokers especially, if you think about it, all day for 16 hours, they're smoking and then they stop to sleep. The body goes through withdrawal at that time. So some people actually have awakenings throughout the night because they need their fix of nicotine. And then caffeine, we'll get into more. But essentially, people will say, well, I could drink a pot of coffee and go to sleep. Well, sure, you could fall asleep, but is your sleep quality as good? And we'll get into that. Working night shift or irregular hours, we discussed that, as well as other co-occurring medical conditions that exist and how they affect your sleep. So they can disrupt sleep. And then, of course, mental health, trauma, depression, anxiety. All right. The next slide. And okay, very good. So a lot of patients think, or people in general, think that sleep is an on-off switch. You're either awake or you're either asleep. Sleep is a repeatable, reversible sedation that you are arousable from. Okay, and so there's 4 stages that it has been broken up into, and stage 1 is the lightest. Lightest stage 1 can even happen when your eyes are still open. If you ever think about a little toddler who you could see their little eyes glazed over and you know they're about to fall asleep, that's stage 1 probably for that little kid. And then eventually the eyes shut and their brain starts to go into deeper sleep. So stage 1 is heartbeats relaxing, breathing is slowing down, muscles are relaxing. In stage 2, and that's quick, 1 to 8 minutes, it's 5% of your total night's sleep. And then we have stage 2. That's gearing up your body to go into those deeper stages of sleep where we get the most rest and restoration and repair. And our body temperature's going down, our heart rate's further slowing down, breathing slowing down. And stage 1, stage 2 is sometimes if you notice you jerk awake and you didn't hear anything necessarily, but you jerk awake, that's called a hypnic jerk. And the idea is it's evolutionary when we used to sleep in trees so that if we're falling, we wake up. So hypnic jerk is actually a normal phenomenon. If it persists throughout the night, then we need to talk. But if it's just initially when falling asleep, that's appropriate. Stage 3. So this is the deep sleep. Everyone thinks got to get that good REM. That's the deep sleep. It is, but stage 3 is truly deep sleep. This is when growth hormone is released. And this is very important for children to get enough sleep so that they get enough growth hormone. This is repairing of muscles, growing. This is also when testosterone is synthesized and released. And so at this point, if someone has untreated apnea and they're not getting enough testosterone produced and released, I see so many, especially men, go and get testosterone injections when it's really, let's go back to the root of the issue. Let's investigate the sleep. If we treat the sleep, we can help naturally improve the testosterone. But stage 3 is the repair, restore, replenish. Memories are stored here. Anything kids have learned throughout the day or adults is stored here at this time. Slowly, that goes away as we age. Men typically after their 40s, women after menopause, we start to see less of that. This is more difficult to wake up from. And then REM, the most famous probably. This is when your brain waves actually look like they're awake. Your muscles are paralyzed and there's a hormone or neurotransmitter. Glycine is released. It relaxes the muscles. So you should be paralyzed at this time so we don't act out our dreams. If you're acting out your dreams, then you need to come see me because that means that either it's a medication side effect or there could be a potential other sleep disorder going on. And those that it's not a medication side effect, it's not narcolepsy, we're starting to realize that people in their 5th decade, if they're acting out their dreams, they have a higher prevalence of developing Parkinson's down the road. So we're learning a lot more in people's sleep of their future health. And we go through this cycle every 90 to 120 minutes. So about 4 to 5 cycles of sleep a night. Next slide, please.
Martha, do you mind before the next slide? We have a lot of excitement and chatter
Yes,
about
let's hear it.
marijuana. Yeah, about marijuana and the THC gummies as a sleep aid.
Okay, so my first question is always, well, why did you decide to try that? And typically I like to try to intervene sooner, but I don't blame people. They're kind of desperate. I'll try anything. But my first question, even with melatonin, I want to know, well, why are you using that? Can we restructure your sleep and sleep cycle and schedules naturally first? So let's take a look. So what the studies have shown, and they've kind of been all over the place, especially since it's not legalized in all the states. Sometimes it's hard to do research. But what they're finding is it could help people fall asleep. But the problem is they don't think it truly helps the consolidation of sleep or actual better, deeper sleep. But what happens is someone will use it. Okay, let me try this for a while. They'll use it for a couple weeks. And they're like, I don't know if it's helping. I'm not sure. Then they'll stop using it. And then as soon as they stop using it, they start to go through withdrawal symptoms of not using it, which fragments their sleep. So they go back to using it because they say, well, I figure it helped then because now it's worse. But really it was the withdrawal that made it seem like it was helping. Now, there are some patients that in clinic, they just swear by it, and that's okay. You know, that's all right, but it's hit or miss with patients. But my first question is, well, let's go back to why you even considered using that, and let's see if we can fix things naturally. A lot of people think being in sleep med, all I do is give people sleep pills. I'm actually the opposite. I get people weaned off sleeping pills.
Would that be the same for supplements we're being asked, such as, any sleep aid?
Yes, supplements.
Melatonin, Unisom.
Yes. Okay, so any kind of over-the-counter sleep aid is likely going to have diphenhydramine, which is the fancy word for Benadryl. And that once again is one of those category of it may help you fall asleep, but your actual structure is not as good. You could be more tired during the day. You could be more sedated. And especially as we age, it has urinary implications, memory implications. So occasionally, if you want to overlap, hey, I'm having allergies, hey, I'm having trouble sleeping, occasionally. But if it becomes a nightly aid, then we got to talk again.
Okay. And one question about the sleep cycle is, do we go through stage one even while we're asleep? So if we go through the cycle 3 to 5 times a night, are we back in that preparing?
Yes. Go to the next, if you can go to the next slide, it's a good
All right.
demonstration of it. Thank you. Great segue question.
Okay.
Okay. So let's get organized here. I know this might be a little overwhelming. And 7 years ago, I really wouldn't have shared the slide with people. But because of the normalization of the watches, people are kind of used to seeing this. And this is called the hypnogram. A hypnogram is a visual representation of our sleep. And it basically shows us where we're at in stages. And to answer the question about the wearables are pretty good at trying to determine when we're asleep and we're awake. Not perfect, but sleep versus wake, they're decent, about 90% effective. I actually have my little Aura ring on here. That's my preferred wearable. However, about 90% for saying whether we're awake or asleep. Actual stages, much less reliable, like 50 to 70%, which is a huge error. Now, what I like wearables most for, to be honest, are trends. I like using them for trends. So let's say you go 3 weeks, don't drink any alcohol or caffeine, and then you start utilizing alcohol at night and caffeine during the day, you will see a change. You will see a change. So trends are kind of fun with them, but I wouldn't take it, it's not definitive. And I really get upset when patients, their next day, how happy they are with their day is what their little watch told them, because they're not reliable enough to make or break your day. So just try to go off feeling and use them as a guidance, but they're not completely factual, and they're not 100%. All right, let's go through this. So this is a hypnogram. So we see our top line. Are you able to see my cursor, Colleen?
I'm not.
Oh, okay. All right.
But I'll drive for you.
No, that's okay. So at the top, we have the awake line. And then as we go down, straight down, we're seeing stage 1 sleep in that, middle light blue. And then we go into stage 2. It's worse. You can avoid the cursor. And we've got our stage. Okay. We're slowly working into the deeper stages of sleep. Now, these are all non-REM. And then we see that pink box, that's REM. So if you notice on the bottom, we have a dark blue rectangle, and it's large in the first hour. In the third hour, it gets a little bit smaller. In the fifth hour, the smallest. That's stage N3, the deep sleep, with growth hormone, testosterone, repair sleep. And that's more copious beginning of the night. And then as the night goes on, if you notice the pink boxes, they get larger and larger. REM is more copious throughout the night. And that's why a lot of people wake up and remember their dreams sometimes, because dreaming is in the morning, or maybe you have to get up, go to the bathroom, you're like, oh my gosh, it's the middle of a dream. REM is more prevalent later in the night. Okay. Now, if you look at that dark blue that tells us our stages, it is going to go back to the stage 1, and even an arousal almost every 90 to 120 minutes. So every 90 to 120 minutes, whether we remember it or not, our brain wakes up. People who have hyperarousal, anxiety, eating disorders, they will be more awake. And the next thing they do with that arousal is going to make or break their night. They could either try to turn over and go back to sleep, or they can check the clock in the middle of the night, which is a huge no-no. They could go on their phone and start looking at reels, which is a huge issue as well. So those arousals are present in all of us. It's just what you do if you happen to wake up at that time from that arousal. Okay, we can go to the next slide. All right. I wish I had my cursor. This is kind of busy, but let's go to the bottom arrows. So you have 2 rhythms that are causing your sleep to happen. You have your circadian rhythm on the bottom with the arrows, and that's just your natural body clock with the bottom blue arrows. And that increases your propensity to sleep at the highest arrow that you see there in the middle. And then homeostatic drive is adenosine in our brain builds up, builds up, builds up, and then that gives us pressure for our brain to want to fall asleep. So when we see the circadian rhythm arrow and the homeostatic arrow in the middle, the highest, then that's when we have the highest propensity to actually fall asleep. Okay. Homeostatic drive can be disrupted by napping, which reduces your pressure to fall asleep at night. So naps can make it difficult to fall asleep or stay asleep. And homeostatic drive can be reduced by caffeine. So we don't have as much pressure to fall asleep because caffeine is an adenosine blocker. Okay. But the takeaways here on the left side, you see the wake propensities during the day. And then later in the night, you see the green arc of melatonin, which is our sleep inducing hormone that helps. Now, if someone is going to take melatonin, it's actually ideal to take it 2 hours before bed. And it was never designed to be taken in 5 milligrams, 10 milligrams. We can use that in REM behavioral disorder or different sleep disorder, but really for insomnia, it's typically 1 to 3 max. And that would be taken 2 hours before bedtime. All right, we can do the next.
Okay. I missed one question. We got it again about magnesium.
Sure. So yes, magnesium is interesting. We use it for a lot of different things. Typically, it can help. It's very anecdotal. It depends on each person, to be honest. We see it help with cramping, leg cramping. The old tale was a bar of soap in the bed, and I still allow people to do it. It doesn't hurt anything, but magnesium can help cramping. Quinine, like tonic water, can help with cramping. So magnesium can help. It just, every patient's a little bit different. But we have seen it help people, yeah, in studies, yes. You just have to be careful because you don't want to overdo anything if you're not being monitored by someone in the healthcare field. Also, I do want to add, today's just educational. This isn't medical advice. All right, next slide, please.
Thank you. Narcolepsy.
Okay, so this is near and dear to me because I've had so many patients. They've had it for 20 years and they've been delayed in diagnosis. I recently had a 78-year-old female who's been struggling with it for 40 plus years. And everyone always told her to exercise more, or she's depressed, or get some sunlight. And narcolepsy is actually a pediatric disorder. We see the first, it can be young. I just saw an 11-year-old earlier today who we're testing for narcolepsy, but teen years is one peak period of time that we see the symptoms come on, and then mid-30s is the other. And then there's one more little blip in the 60s and 70s, actually. So those are the peak onsets. But I wanted to talk about narcolepsy because we often see an overlap with eating disorders, because narcolepsy is with basically we don't have enough orexin receptors, and orexin has to do with food, dopamine, and regulating sleep. And so some people overeat, and so we'll see their growth curve increase drastically with food, and their BMI will go up drastically. So then what happens is everyone just thinks they have apnea, and then they treat apnea and they don't look further. But really, that growth in BMI was because of their orexin deficiency, and they truly had narcolepsy underlying that. But the symptoms of narcolepsy, it says hallucinations. They're actually called hypnagogic and hypnopompic hallucinations. And what that is, on the fringe of sleep, whether you're falling asleep or waking up, you're in between this dream, wake, sleep situation where you kind of look around and you're like, did I just dream that? Is this dream still in the room with me? Sometimes people will hear the figures from their dream while their eyes are open. They know they're awake. So that's what that is. Sleep paralysis. Somebody asked about this earlier. It's not only with narcolepsy, but it's seen with narcolepsy. Sleep paralysis is when there's REM intruding. You've awoken, your eyes are open, your brain's awake, but your body feels stuck. And the reason you feel stuck is because your body's still stuck in REM. And REM is when those muscles are paralyzed. So sleep paralysis is a hallmark sign of narcolepsy, but we can also see it in sleep deprivation and sleep apnea. Loss of muscle control is more like weakness with extreme emotions. Orexin pathway also shares the pathway with emotions. And so we can actually have people have muscle weakness with laughter, joking, anxiety, anger. So that's what we also see in narcolepsy. And then the two cardinal ones are the sleepiness, daytime sleepiness. It doesn't have to be falling to the ground sleepiness, but just tired. If you have tried everything to help someone be more alert and awake during the day, and they're still just so sleepy, send them to sleep medicine and really try to find sleep medicine. Some sleep practices have just become CPAP factories. Try to find someone who really looks at the whole patient and good, solid sleep. And then this one's really interesting. I'm hoping there's some counselors in here and therapists because the poor nighttime sleep, that is underrepresented in literature as part of narcolepsy. If you have tried, if you know a patient has tried multiple sleep meds and they still have disrupted sleep, we have to look into narcolepsy. And the poor nighttime sleep, the other part of that is with narcolepsy on-off switch of, and I told you it's not an on-off switch, but the on-off switch of sleep is broken. So their brain wants to wake up when they should be sleepy, and it's sleepy when they should be awake. When I showed you the hypnogram, what you notice is it's more like a stick shift car changing gears throughout the night. But essentially, poor nighttime sleep, daytime sleepiness, usually co-occurring anxiety, depression, or ADHD, migraines, think narcolepsy. Are there more questions?
No, Autumn, you're not seeing any, right?
Doing okay right now? Okay, great.
Yeah. Thanks, Martha.
Yes. Okay, so we can kind of tackle this together, but this is a beautiful Venn diagram, and yes, it's beautiful, of mental health conditions, eating disorders, and sleep disorders. And if we just take a look at the overlap there, mental health and sleep, insomnia, hyperarousal, and nightmares. Hyperarousal would allude to that every 90 to 120 minutes, that a little arousal period, these people are waking up. They're very awake. And on top of the 90 to 120, they may be even more so in between each round of sleep. We're going to go into the sleep-related eating disorder and nocturnal eating in a moment here. Depression, anxiety, overlap of the eating disorder and mental health, and then emotional dysregulation of the hormone imbalance of orexin, ghrelin, and ghrelin, and cognitive rigidity. And I think we'll get more into that.
Yep, we will.
Okay,
so I'm going to move on.
Go for it.
To our medical concerns.
Yes.
So we wanted to show you all how the overlap of when it translates into this compound medical psychological concerns. So you can see a lot of the symptoms and eating disorders are here on your left. These are the pieces that we were talking about of these medical complications that can lead to death, right? So malnutrition, not just an eating disorder concern, the electrolyte imbalance, dehydration, hormonal imbalance, bone density. So, of course, the heart, the main organ. Some of them are harder to see right away. That I often say to patients, like, you're struggling, but you can't see what's going on the inside, and their bodies are just so resilient at a young age that they're not seeing these consequences, so to say. And then sometimes we see that's what kind of starts motivating the teens or adults when they start to realize how much it is impacting their health. It's inevitable. We can't run from it. So then we see on the other side the sleep disorders, which you can argue there's going to be, even in the eating disorder and sleep disorder side, there's a lot more that can fit in that both section. Any questions on the...
We have a question here about nightmares and sleep, and a lot of clients who live with an eating disorder and some sort of trauma and nightmares.
Yes. Okay. So a lot of trauma with eating disorders. A lot of insomnia, nightmares with trauma. So this is a good place to talk about behavioral sleep medicine, which is a sub niche of sleep medicine. Behavioral sleep medicine includes cognitive behavioral therapy for insomnia, which we'll talk more about, but they also do, and some therapists, if they're present here, may also do this. They work with the nightmares. So the nightmares, typically it's best to do some sort of, there's a program, it's called image rehearsal therapy, IRT. And then there's CBTN, which is cognitive behavioral therapy for nightmares. And a good behavioral sleep medicine psychologist is a great resource for these. Now, there are medications we use as well, but I'm a fan of let's try the natural interventions first, and then we'll add medications on as needed. Sometimes we do both, of course. One of the biggest referrals, resources I use and refer to is called Dr. Lullaby, and we'll have it further down in the slides here. Dr. Lullaby is the name of a program, and she recognized, she's out of University of Chicago originally, and she realized that there is not enough behavioral sleep medicine psychologists and clinicians out there to treat all the issues. So she started this telehealth platform. So I refer a lot to her, and I've had a lot of great luck with them, but I utilize them for CBTI, which is cognitive behavioral therapy for insomnia, CBTN for nightmares. I utilize them for night eating, as well as sleep-related eating disorders. And so they really umbrella all the behavioral components to nightmares and the eating disorders linked with the sleep and nighttime. So behavioral sleep medicine uses the image, the IRT and the CBT and for nightmares, as well as there are medications we can try.
Awesome. Let's get into the sleep-related.
Yes, there we go. A little segue here.
Yeah, absolutely.
Okay, so yeah, go ahead. Do you want
I was
to
just
get
going to say
started?
one area where the relationship becomes really important is the nighttime eating disorder or eating behavior. So I don't know if you guys remember back up in the beginning when we were talking about different types of eating disorders. This is one of the 5 subtypes of OSFED. So that's what you have on the right-hand side. And then what's really important to the difference of the two is the night eating syndrome is the awareness. And then Martha's going to talk about how the other one is not. So Martha, I'll let you get started on that, and then we can continue with the night eating syndrome of the difference with the awareness.
Sure. So the sleep-related eating disorder is complete or partial amnesia. You have no idea you're doing it. Sometimes this is because of another underlying disorder, or it could be because of a side effect of a medication. I recently had a patient, she didn't believe her son, but she said, he told me I got up and made a turkey sandwich, ate it, and went back to bed. And she's like, I had no idea, and he was lying. And I'm like, well, I'm not sure he was lying. And she's like, well, I did wake up with crumbs on me. I'm like, you're on Ambien. That is a potential black box warning for Ambien. So some of it is medication induced, and then some is not. They're not on a medication, they still do it. And that is a behavioral sleep medicine referral. They work with them. And basically, it has to do with timing of when they're sleeping, when they're eating during the day, and making sure they're having enough calories during the day. And so there's a link there. But the sleep-related eating disorder is they're unaware they're doing it in the night. And then as far as treatments, there's benzodiazepines. Basically, they relax the arousal of the brain so that they're not getting up and doing this. But really, like I said, I really try to do behavioral sleep medicine first. And then lastly, we'll start talking about medication options for this.
Okay, thank you. And night eating syndrome, it's associated with 3 of the following. So lack of appetite in the morning because they consumed off schedule. We'll talk about normalized eating times, the strong urge between eating from dinner and sleep onset. So I have talked with patients of, are you someone who eats dinner early and goes to bed late? You are going to be hungry and we can have snack then. Or are you someone who eats dinner really late and goes to bed, at a normalized time, then maybe we have a snack before dinner. So just making sure that we're having that like every 3 hours. So it's not necessarily you can't eat after dinner. And this I think all of us are aware that it's not there's not much truth validity to the fact that you can't eat right before bed because it's gonna go right to fat. Our body knows what we're doing. And then another component is insomnia or difficulty maintaining a sleep. It is not necessarily to fall asleep or return to sleep. So depression could be worsened, mood in the evening because of that cyclic behavior. It's reoccurring. So once we become creatures of habit, I used to have a lunch break every day at noon. After the third month of this work, this job I had that every day at noon we stopped to eat. Sure enough, on Saturdays and Sundays, I knew it was noon. So we get in these patterns and behaviors, just like if we have a kid wake up in the middle of the night who wants a snack, or a pet, they're probably going to want that snack in the middle of the night. So really working with a patient on their schedule, the food that they're consuming. Andrea made a good point. The food that we need to be eating before bed is a specific amount of carbs and proteins in those food sources, that it's not just kind of a free-for-all just to eat and fulfill our hunger cues.
One more
Colleen,
thing
we
to
have a
share.
question here.
Oh, go
Oh,
ahead.
I'm so sorry.
No,
We
it's
have a
okay.
question here about providers giving more sleep aids without working with clients' stimulant intake, disordered eating patterns, or even considering natural or nutritional needs without medication. Any guidance on how to improve communication with providers, as these meds are merely a sedative and not quality sleep aid?
Yes. That is a large frustration of mine, usually in sleep medicine. And it's not malicious, it's out of good intent to try to help, but they've been put on a number of medications that we have to slowly peel off. So one thing I love about I'm learning about SunCloud and just all of you people who showed up today is this is how medicine should be. We should be collaborating, we should be talking. This should be normalized what we're doing today, and I'm grateful for it. But it's funny, I have a number of my patients, therapists, psychiatrists, primaries in my phone saved, and we communicate, and they're just shocked that I'm willing to call their other providers. So it's a great question. It's very hard to get through to some people and communicate with them to collaborate on patients. It's all just about recognizing it early and referring to the right people. And that's the $1 million question, to be honest. I mean, I would love a better way to collaborate and talk. And I know Epic makes it a little bit easier for providers to talk and communicate. I don't utilize Epic. We're a small private clinic, but it's communication in any way you can. So I do have their numbers, and I talk to the ones that are on the higher end, or if our patient requests it, of course. But yeah, the earlier we can do, and just education like this. Like I said, I don't like nearly any sleeping pills, but we do everything as naturally as possible. And if we can reset people naturally, then that's my goal. But occasionally there are refractory, situations. So it's not a great answer, but I would love to see that too.
All right, were there more, Autumn?
That's all so far.
Okay, so whether driven by sleep disruption, malnutrition, or both, the brain can, I think you guys are all seeing now how impacted the brain can be affected by this. So sleep deprivation significantly can impair the cognitive, emotional functioning, the executive functioning, impulsivity, mood instability, decision making, reward seeking behavior, of course, reduced motivation when we're tired, increased cravings, elevated cortisol. A lot of things that these are the things that we want to improve on, and this is where those treatment modalities could come in. So, Martha, we're going to talk next about the part of how the hunger, satiety, stress,
Sure.
reward signaling, sleep and hunger
Sure.
hormones, which was previously asked. So some people do have
Yes.
interest in this.
Perfect. Yes. So it could be because of apnea, it could be because of insufficient sleep. But our hormones will be affected by sleep deprivation. And remember that case earlier, I said someone said, "Oh, I get 4 to 5 hours and I'm fine." Well, that person ended up having severe sleep apnea. So even of the 4 or 5 hours they were sleeping, they were not truly sleeping that whole time because their brain was aroused, waking up and keeping them breathing. So what happens is ghrelin, however you want to pronounce it, that increases. And I always think of that as the ghrelin, that reminds me of the word goblin. And I just feel like it's a goblin in my stomach telling me to eat.
Yep.
Eat.
It's
Okay.
not
And that's
satisfied.
telling us yeah, that's telling you to eat. So now this person, just because of their sleep, is now more hungry, they're craving, And also when we eat, dopamine rises and it wakes our brain up a little bit. Leptin. So leptin tells us you're satiated, you're full, stop eating. Well, we know that we get leptin resistance with apnea or insufficient sleep. And so our body doesn't know to stop eating. Cortisol, the key word everybody wants their cortisol checked these days. Well, increased levels of cortisol. It is a normal stress hormone and it's okay to have some cortisol. But if you're in a chronically stressed state and have elevated cortisol throughout, elevated inappropriately. For example, during the night with apnea, cortisol is elevated multiple times when it really shouldn't be. So that is where we also have sugar retention and this emotional eating response and vulnerability. Orexin, we if you recall, we discussed that with narcolepsy. And orexin has to do with being awake, our eating, our emotions. So it's food-seeking reward pathway. And then dopamine sensitivity changes. Once again, dopamine is part of that pathway of the rewards. This is good for us, do it. So initially, it's part of our very primitive brain of do this, it's good. Sex, good. Food, good. And that's still what it is. So our brain likes it, but now we just have so many more dopamine inputs. So that's the link there.
Okay, so I'm going to bring in a question. I think now is just a good time. We might have be instead of later, but just about nocturnal hypoglycemia, which absolutely we can see that in all different types of, or all the types of eating disorders because of the restriction of calories or the malnutrition status based on, whatever their eating disorder coping skill is. So the low overnight blood sugar drops can trigger the stress hormones, of the cortisol. So then what's really important again is that the structure of the mealtime, the snack before bed to help stabilize. Because yes, we can absolutely see someone waking up, the anxiety, sweating, all that comes with that. So I hope that helped answer that question. So, Martha, this brings in a question. Someone asked how to test for narcolepsy.
Oh, okay.
If you want to answer that, and then we'll go into the screening tools that we're going to utilize.
Sure. So let's say someone comes in, I'm excessively sleepy and I have trouble sleeping. Well, you have to rule out some other things first. So you have to rule out apnea, you have to rule out leg movements. So you do an in-lab sleep study. It doesn't have to be in-lab initially. You could do a home one, see if there's apnea or not. If it doesn't appear to be apnea and you're still tired, you're still having trouble sleeping, then it could be, along with clinical decision and clinical history, narcolepsy. So what that kind of test that looks like is it's a spend the night with all the wires on, and then the next day you wake up for 2 hours, and then every 2 hours you're asked to close your eyes and engage in sleep. Most people think, even people with narcolepsy say, I can't do that. Well, we're going to try and see what happens. And we look at how quickly does your brain fall asleep and how quickly does your brain go into REM sleep. And based on that numbers, that will give me the information to help you and decide, is this truly an issue or not? So it's a NAP test called an MSLT. That's the specific one for narcolepsy. And then,
right.
Yes, so that's specifically for narcolepsy.
So these are some screening tools that we want you all to be able to take away. Some might be used by your practices. We do a lot of work. I love something about SunCloud with Dr. Kim Dennis, a lot of research. So gathering this data, looking at progress, using valid tools. So one here that I just wanted to bring in is the PHQ-9 and EDQ. I'm going to show you just an example of one question that we have on the next slide. But dietary recall and their structure of times is just as important as the food that they're eating. So looking at that, as well as making sure that we're talking about beverages. A lot of drinks have calories in it and the caffeine that some people don't understand how the impact is. And the EDQ is great for eating disorders in general. I suggest all of you taking some time to look into that. We would have loved to spend almost half of this just looking at these valid tools with all of you. One thing I learned from Martha is she is a big advocate for this stop bang one. So I think this is the most important one that we wanted to bring to all of your attention.
So stop bang, I think it's great for outsiders. In sleep medicine, I use more the Epworth Sleepiness Scale. That's just how sleepy someone is in certain circumstances. But stop bang is great to just have as You can just even have it laying, on the wall or laying on the counter, and someone could look at it and say, "Hey, I check a lot of these boxes." But honestly, it's talking about snoring. How often are you tired? Has anyone ever observed you stop breathing? Blood pressure, body mass, age, neck size, gender. However, this could all be summarized in if you snore, you should at least get a home sleep test. That's it. If you snore, everyone thinks, oh, everyone snores, or that's just Uncle Al. He always snores. And that's just who he is. Like, no, that should be investigated because snoring is a clue that an airway is tight. And if an airway is tight, it could be affecting oxygen levels. So these are all fancy and nice, but even if you just ask, do you snore? Um, Women always say no. I'll give you that. So ask their husbands or their partners.
That's great. So does that mean men always say yes, or the wives say
Men say whatever they say.
That's great.
But yes.
Okay, so I wanted to show, like I said, at SunCloud, we do treat eating disorders, and about a third of our population. So this is just one example from a PHQ-9, how satisfied you are with your sleep. So this was a study of 390 patients that we pulled, 120 of them with eating disorders. So the results were, you can see here the difference between the blue and the orange. The orange is the eating disorder diagnosis. And a lot of dissatisfaction compared to someone that maybe is normalizing their nutrition and not experiencing any of those medical complications that is helping support the sleep. So is it the eating disorder or is it the lack of sleep that's causing the next day's behaviors? All right, so we really want to get into two more topics just for sake of time. We're going to get to them. Hot topic, caffeine. So one factor that frequently complicates both sleep and eating disorder is caffeine use. A lot of misuse of caffeine in the eating disorder population because it can suppress our appetite. It could increase alertness. So having this false sense of energy when we're not getting it from the calories that we're supposed to. It also can really help support people with exercise addictions to be able to achieve their goals. And just staying awake even when they're not getting good sleep. So a lot of that is important to pay attention to. I just wanted to add in here, I found this very interesting so that FDA allows us to have up to 400 milligrams, and it's saying about 90% of the population is consuming it and at an average of less than what the FDA approves. So I was really surprised to see this, and this was from the FDA's research that if you look over here, how many of our adolescents are consuming this energy drink of 150 to 300 milligrams? And that's, at a younger age. So coffee, we're looking at 80 to 120, but this is where a lot of calories also lie. And then soda, calories if it's not diet, but 34 to 54. Mountain Dew, I feel like maybe isn't as common anymore, but I know they now have energy drinks, but the soda itself was the 54 milligrams. So if you're having several of those a day or a variety of these is how that can really add up. So the inadequate intake, of their food, it's going to result in fatigue. And then they go to coffee, and then Martha was talking to us about how we're then looking for that coffee again and the caffeine again. That is going to create that cycle of we're fatigued, so let's do it. And I think what you were saying, Martha, is that the imbalance of the two is actually what the issue is, and it's not actually the caffeine that was helping.
Mm-hmm.
So this is something that we really pay attention to in the eating disorder population. I'm not sure how much you discuss it with your patients, but I'm always challenging.
Me? Oh, yes. Often. And I'm actually really curious. I mean, I'm not questioning the stats, but I'd be really curious to dive into the study. Like, when was it done? What age group? It'd be really interesting to break that down because that's what I'm shocked by how the milligrams they're saying. It's really
Yeah, but I felt like it was important to still share with people, instead of leaving it out. But I was like, wow.
No,
And the
definitely.
challenge for myself when I have my 1 to 2 cups of coffee in the morning, and then I'm always striving for that, Diet Coke, in the afternoon, which I challenge myself, like, should I be having a snack instead? And then I did see another study that around 30% of adolescents are consuming energy drinks. We see a lot of patients bring them to program. And I just think of, like the financial cost too.
Yes.
Any thoughts or questions about caffeine? Because we do feel that it's a hot topic.
I think I have a slide on this, but next, just kind of talking about the sleep cycle with caffeine. But it's interesting, caffeine, um, it could, if you're on an empty stomach, it can hit you in as quickly as 5 minutes, and it's 99% absorbed. So it's not just about sleep and eating suppression, but increasing anxiety, as well as excessive caffeine is linked with a heart arrhythmia called premature atrial contraction. So it's really interesting that people seem to think it's very benign. And yes, there's articles on how it's helpful, but within reason. So the caffeine cycle is interesting because it's you have poor sleep, you wake up tired and exhausted, you drink caffeine to help almost as soon as possible, typically for a lot of people, feel energized for a little bit. So you start to feel effect. Like I said, it could be 5 minutes, but its peak effect is at about 45 minutes. The half-life of caffeine is about 5 hours, and then it's out of your system in 10-ish hours. So that means if you're trying to go to bed at 10 o'clock at night, you really shouldn't have caffeine after noon. And then you'll need more caffeine throughout the day, and then poor sleep because it affects stage 3 sleep and REM sleep. And poor sleep at night continues the cycle. So it's just interesting how people are just like, oh, I need the caffeine. Well, you need the caffeine because you're having caffeine and disrupting your sleep. So very interesting.
And if we could just take a second to look at this cute image that you shared, Martha, of, oh man, I really shouldn't have had that coffee in June for a bear going into hibernation. So exaggeration and stretch, but it's good to know of if we're going to bed at 10 o'clock, what time we really should stop that. Oh, someone talks about caffeine curfew. I would like to take on that term if that's okay. Thank you for
I
that.
love that.
Yeah.
I'm stealing that too. Thank you.
Yeah, and then another question's about B12. So my thought about B12, given that like we might have a vitamin deficiency, that's really going to help. It doesn't act as like a stimulant like caffeine does to help with energy. All right. Next topic we wanted to go over because this is a hot one. Newer medications are changing the conversation around sleep, appetite, weight, body, and that's the GLP-1. So Martha's going to share some information with us on that.
Okay, yes, this is a hot topic, sometimes controversial, but I just want to I want to link it to sleep apnea because that all, sleep apnea worsens anxiety, depression. Real quick story. I had a patient. She came to me, talked about how poor her sleep was, and somehow no one had ever recommended a sleep study along her journey. She's been on disability for about 14 years because of her depression. So I said, okay, well, we definitely need to do a sleep study. Let's just kind of see what's going on and then go from there. Turns out she had severe apnea. We treated it. And the next time I saw her, she said, will you help me get off disability? How do I do that? I've never, ever had anybody ask to get off of disability, but she was so excited that this apnea and this disrupted sleep was such a major part of her mental health that she felt that she could now join, the workforce again, full time. And that was just really exciting. And that case, I'll never forget it. That was a few years ago, but I was just so amazed at how much the apnea affected. But that kind of leads me into now we're utilizing so tirzepatide, which is actually GLP-1, glucagon-like peptide on the one receptor, and then receptor agonist, and then GIP. And so that's dual. So what they found in the study, the SURMOUNT trial that they did, was that patients who utilized tirzepatide with CPAP versus without CPAP, and it reduced their apnea significantly. So with no CPAP, it reduced their apnea 55%, and then on CPAP, 62%. So that's how they got the indication for treating apnea with tirzepatide. A lot of people think, oh, Zepbound. If I take Zepbound, that treats my apnea. I don't need a CPAP anymore. No, it's an indirect way that it can affect the apnea. So the weight loss, because weight loss is part of the equation in apnea for 2/3 of people. If we lose the weight, it reduces the severity of the apnea. There are thin people with apnea. It could be craniofacial, it could be genetic, but for the people that it is part of the equation for, It is helping reduce apnea. And then just to go with eating disorders, I mean, you can touch more on that, but it's just interesting that a patient I saw he said, look, I'm drinking too much alcohol. He had apnea as well, and he had weight to lose. And I said, well, do you want to try this? We're starting to see that it helps with addiction and alcohol. And then just anecdotally, I was talking to a colleague in the pharmaceutical company, and they had a connection with someone in the alcohol business and said their sales are going down, and they were blaming the GLP-1s because people are drinking less. So I just thought it was interesting, but it's exciting because there's receptors in the brain too. So we're starting to see that be part of the impulsivity of eating, and food noise is like the new word of the last 5 years, it feels. So anyway, that's just a little bit on the GLP-1s as well, since we were here talking about it.
Yeah, absolutely, Martha. With eating disorders, it can, the food noise, but what's really important is looking at Hayes approach, health at every size, and not saying that every body size is healthy. We need to really make sure that we're focusing on the word health. Can someone's health be improved if the size of their body were to change? No different than we're looking at someone in a smaller body who could benefit from restoring some weight. So the ability to sleep at night, the breathing complications, their, ability to do ADLs, are they having a lot of other diagnosis and disease states because of the size of their body that we can get off some medications or improve blood glucose? So there are some benefits, and it's something that we have to be very cautious about, that one eating disorder doesn't turn into, oh, this weight loss feels so good, I want more, more, more. I love the food noise being gone. I'm not going to eat all day.
Yeah, and I want to add one more thing to that real quick. I actually talk to my patients a lot about malnourishment on GLP-1s because they're not eating enough, or they may be eating small portions, but not of the right food. So that's a new conversation that I didn't even think I'd be having, but it occurred to me these people aren't eating the right foods and what little food they are eating. So
we can have a donut and still lose weight. So it really helps, a donut instead of breakfast and lunch. So what's really important is hopefully that the doctors that are prescribing it are monitoring weight, protein, lab values. One more, and then I
agree, Dawn. Dawn said, I'm a believer that anyone on a GLP-1 should be working with a dietitian, and I agree. And if you want a job, come to the clinic.
Hey, no, you can't take her.
Is she with you?
But Dawn has a good point. I think it's getting really missed that some providers are giving the prescription and there's minimal follow-up. That could be really scary. It's about the food, and the goal is to change behaviors. How are we teaching someone to change behaviors if we just hand a prescription and don't discuss it? Okay, so last few minutes, I'm sure you guys all want to know, what do we do about this? So for the nutrition side of things, the nutrition interventions, we want to look at a harm reduction approach. How can we decrease behaviors that are happening to help improve our nutrition status, quality of life, relationship with food and body? I don't have an expectation of a patient to stop all their behaviors within a week, eat 100% of their meal plan, and not engage in any exercise or binging or purging. I would love to say that our jobs aren't necessary, because that would mean these disorders don't exist. So it's not a chosen behavior. It's something that we want to work on, and getting them involved in their goals, I think, is super important. That's why we're not the cookie cutter of, oh, you have anorexia, so this is what we're going to work on. You have RFID, I'm going to challenge you to try different foods. We want to see what the patient is actually interested in. With that would be a meal plan. So prescribing a meal plan specifically to each patient of how many grams of carbs, protein, fat, fluids, their fruits and vegetables portion, teaching them what portions are, teaching them what food groups are. We can't assume that they know this information. And trying to set standard times. Limiting caffeine. I love caffeine curfew. And then appropriate exercise. We all need movement. Maybe someone who struggles with excessive exercise needs to understand what joyful movement can feel like. Finally, that we're moving our body, and it's not for calorie reduction specifically. So each different diagnosis and behavior or symptom can be treated differently.
Can we advance the slides?
I am so sorry. I'm sorry, y'all. But Martha, I'm excited for you to share about CBTI and Dr. Lullaby again. So if you wouldn't mind.
Sure. So cognitive behavioral therapy for insomnia, I even saw a number of attendees talking about their insomnia. I would definitely recommend looking into CBTI, and here's why. It's about 70% effective, and it helps not only reduce the necessity for sleep meds, but often gets people off sleep meds because you build the confidence propensity to sleep on your own. So the way this works is you use a sleep log, and I want to mention this before I forget. There is an app called CBTI Coach. CBTI Coach. It's a little purple square with a moon in it, and it is put out through the VA, and it's for free. And it has all kinds of little stories you can listen to, information about insomnia, and you can log your sleep there. So my patients go on there, they log their journals for me, and then I review their data with them. And CBTI and BBTI are very similar. Cognitive, it's how you think about the sleep, but then behaviors is I can, often help people just with BBTI, brief behavioral therapy for insomnia. And that's changing what time they're going to bed, what time they're waking up, their behaviors they're doing in the night when they wake up, and just to create a more 24-hour period of success for sleep. And so there are programs like Dr. Lullaby. I'm sure there's others. That's just the one I utilize and I'm most familiar with. I'm sure there's apps and all kinds of other things, but I've had success with Dr. Lullaby. So CBTI is specifically for the insomnia portion that we know overlaps with eating disorders and anxiety, depression, mental health. So CBTI, huge resource, underutilized. Dr. Lullaby is one resource, and then CBTI Coach is a great resource. And there's a lot of different places too that if you want to integrate this into your own practice or clinic, you can learn BBTI, and it's a great, great resource for patients. They're so happy, and it's usually just a few little switches that we can do to help them approach that. And then this 10-3-2-1-0 sleep rule, this is another thing. Print it out, put it up. 10 hours before bed, no caffeine. 3 hours before bed, and I know you dietitians can supplement this, but no food or drink, but you guys can do your
Well, within
proteins and whatever.
limitations. So maybe
Yes,
no,
yes.
but might leave low.
Yes, and then 2 hours before bed, reduce work. Some people are checking emails to the second they go to bed, and that increases dopamine as well. 1 hour before bed, close everything down, shut things down, do something sedating, get your brain ready for sleep, get that melatonin production going, and then don't fall asleep, don't go into the bed until you're actually sleeping. And get out of bed each time. It's more important to get out of bed each day at the same time versus the same bedtime, actually. But that's a little overview on that.
And let's not talk about snooze buttons. That's not maybe a personal attack on all of us.
I love the snooze button.
I know we're nearing the end, but we had a quick question about sleep
Yes.
hygiene and sound machines. Helpful or hurtful?
Sound machines can be great. Sound machines can be great. I don't like clocks in the room or checking clock. Checking clock is arousal in the middle of the night. Checking clock right before bed. So yes, I would just say they're great. They can be great. Yeah, that's perfectly fine.
I want to make sure to share our contact for Autumn, our great MC today, and Diane Fagenrow, who might be the reason why you're all here. It's really important that you guys have the contacts for them, that you can reach out anytime. They can also get in touch with Martha. She's not part of SunCloud. She's a near and dear colleague to me, so I really appreciate her taking the time from her patients, her family, to do this with us. So we can get you guys, anyone in touch with her, and you will receive our slides. We hope you guys learned a lot and had some fun in learning about sleep.
I had a blast. Did you have a blast?
Yes, I did. And hopefully there's some key takeaways you can take back to not only your own patients, but yourself. We're all human. We can all make some changes and behavior modifications.
Thanks for coming, guys. Thanks, Colleen.
Thank you.
I got to get back to work.
Yes, please do. Your patients need you. Thank you, Martha.
Thanks. Bye-bye.